This is a very interesting, unique case. A patient was diagnosed with borderline resectable pancreatic adenocarcinoma. And what's really unique is that this tumor is particularly challenging with poor prognosis, limited options for treatment, and considering, her age, her personality, she was not interested in surgery at all. So we started with the best possible option, chemotherapy, tolerated fairly well for the first cycle. Second cycle complicated by febrile neutropenia, infection, and this is what you expect actually for those patients while going through this uh, relatively tough chemotherapy. Despite the fact she doesn't have comorbidities, we're talking about relatively well-preserved 75 years old. But this is what they usually go through with chemotherapy. She refused further treatment, but she was keen on pursuing treatment as long as it's preserving her quality of life. And here comes the unique aspect. We went for precision medicine to help us. We sent for molecular profiling, and the tumor came back. The result came back without mutations, low mutation burden, but uniquely amplification of a KIT. This amplification hasn't been reported in human adenocarcinoma. However, we know that KIT can be targeted as a gene can be targeted by a long list of tyrosine kinase inhibitors. We chose the most tolerable that we have long experience using, and we started using imatinib. And interestingly enough, she had excellent response with stable disease for about 3 to 4 months. Also, this is the first time we see adenocarcinoma responding nicely. Biochemical progression started. So we elected to start some oral tolerable chemotherapy known to have activity in adenocarcinoma in combination with other agents, not alone, but we started it on a metronomic basis. Again, this approach to be used in adenocarcinoma hasn't been attempted before, but we elected to use it because the patient was interested in treatment. But again, she wanted something that preserved her quality of life, nothing intravenous. So we chose capecitabine on metronomic basis, a bit unique because we elected low dose on alternate weekly basis. And the patient continued to have stable disease for a total of 16 months on treatment. We are talking about a tumor that is known to have a 5-year survival at best of less than 10%, even after surgery. The disease-free survival doesn't go more than 10 to 20%. So our patient had a 20 months of excellent quality of life, excellent response to a tolerable treatment guided by molecular profiling and precision oncology. A couple of things actually unique about this case. There is no question that this tumor behaved in exceptionally excellent way responding to treatment and not going progressing aggressively and fast as usual. A testimony to the different subtypes of pancreatic adenocarcinoma and different clinical behavior recently described in the literature, especially it did not have any of the 4 dominant mutated oncogenes described in pancreatic adenocarcinoma. So our case illustrates the importance of subtype guided therapy to guide our choice for treatment for all tumors, and especially and particularly for pancreatic adenocarcinoma. Probably it raises the importance of paying attention to the subtype with low tumor mutation burden, possibly KIT amplification, could be guided by treatment with tolerable tyrosine kinase inhibitors plus metronomic therapy, leading to preserved quality of life for excellent period of time, 16 months, 20 months of progression-free survival. The patient is still alive we're trying to manipulate her treatment as we speak, again, pending molecular profiling again, to see what can we offer her. But she's in excellent quality of life, despite the fact that she is challenged by a poor prognosis tumor. For this particular patient, definitely we managed to offer her an excellent option for treatment based on molecular profiling. So we are attempting, once she progressed 20 months after her initial diagnosis, and her progression is only biochemical, so she is still doing great, still maintained on the treatment despite the biochemical relapse, but we are sending for molecular profiling to inform our decision, considering that we know they do have dynamic behavior. So probably we are hoping second molecular profiling will inform our decision for further treatment for her. I believe our case emphasizes the importance of subtype directed therapy to identify the best possible option for patients with challenging tumors, particularly pancreatic adenocarcinoma. We need to move forward from only one size fits all using chemotherapy, multi-agent chemotherapy with significant toxicity, despite the fact that it is manageable, to subtype directed therapy, exploiting our knowledge of molecular profiling for different subtypes of pancreatic adenocarcinoma to inform our decision to treat those patients differentially based on their molecular profiles. And hopefully, this case support that there is a possibility to use different approach to treat patients with adenocarcinoma rather than one size fits all. Metronomic chemotherapy could have a place, at least for those with a low tumor mutation burden, and targeted therapy together. Probably this is worthwhile exploring on a larger scale.